Okay, thank you for joining us today. Today we have Dr. Silvio Nadalin joining us from Tübingen in Germany. Dr. Nadalin will be giving us a talk about update on transplant oncology, status quo, and future perspectives. Thank you for joining us, Dr. Silvio, and the floor is yours.
Thank you, Hashim, for inviting me to join this very interesting and important meeting at every Monday you have. I follow not always, but whenever I can, I join too, and I always have the possibility to learn a lot from you all. This is a particular topic, transplant oncology, and I don't know how many of you are being interested on this, but to know something new, something different, I'm sure is going to involve all of you performing oncological surgery, some in any form. So, what is transplant oncology? Transplant oncology is any application of transplant medicine and transplant surgery in the treatment of hepatobiliary malignancies, primary and secondary one, with the aim of improving patient survival and quality of life. Remember, patient survival. We are not talking particularly in the setting of colorectal metastasis, not tumor-free survival, but patient survival, overall survival. Transplant oncology is getting more and more an important role in transplant medicine, transplant surgery, because the techniques of transplantation are very good and probably every year getting better in terms of patient graft survival. You have new systemic treatments with the synergies between transplantation and oncologies. We have a decrease of standard indication for liver transplantation because we have therapies or treatments for hepatitis B, mainly of hepatitis C. There is a fantastic progressive new development in tumor and transplant immunology with the important interplay among both disciplines. And we are new technologies being introduced in transplant world, like machine perfusion, which probably may allow us to expand the potential organ pool without compromising the outcomes. Transplant oncology is based on main 4 pillars, and among the 4 pillars, I'm gonna talking about mainly of evolution and at the end of extension. Evolution of multi-cancer care, including advancement in solid organ transplantation. In other terms, extending the indication of standard liver transplantation, and extending in the next part, in the last part of my talk, the extension of standard traditional margins of surgical oncology into liver transplantation. We can summarize, this is the timeline of liver transplant oncology during the last, let's say, almost 30 years, starting with the liver transplantation for hepatocellular carcinoma, and 20 years ago introducing liver transplantation for perihilar cholangiocarcinoma, 2007 Mazzaferro proposing liver transplantation for metastasized neuroendocrine tumors, and the last 10 years liver transplantation for colorectal liver metastasis, and very recently also for huge intrahepatic cholangiocarcinoma. Let's start talking about the liver transplantation for hepatocellular carcinoma. Everything started many years ago with the Milano criteria, which has been expanded more and more, becoming huge in terms of acceptance of numbers and size of the tumors. You have the USSF, Dallas, Valencia, up to 7, blah, 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 and going up to the METROTIC 2, which is the most recent and most used score or method of indication for hepatocellular carcinoma. The most important thing is that until now, most of all the methods or scores for liver transplantation for hepatocellular carcinoma have been based on the geographical aspects, namely the number and the size of the tumors. But we should think out of the box and mainly considering the biology of the tumor more than the geometry. And there are different criteria measuring the biological character of hepatocellular carcinoma. Among all of these listed parameters, the response to downstaging and the alpha-fetoprotein values, absolute value, and mainly the change of alpha-fetoprotein values according to the therapy performed in terms of bridging to liver transplantation, seems to be the most important reliable biological parameter of these tumors. Of course, grading, PIVCA, PET-CT scan, test of time, and all the rest, and different combination of all above markers may give you important criteria, selection criteria for hepatocellular carcinoma. The response to downstaging and alpha-fetoprotein has been so recently demonstrated to be very reliable parameters in the XXL trial recently published by the group of Vincenzo Mazzaferro from Milano, which showed clearly that tumor which can be downsized and transplanted into Milano criteria, they have excellent results. So the standard and mainly in particular the patient beyond the Milano criteria. Therefore, I can personally suggest to use the new Metro Ticket project, the so-called Metro Ticket 2.0, for analysis of competing risk of death after liver transplantation for hepatocellular carcinoma. You can find a Metro Ticket calculator in internet, which is very easy to apply. You provide, you log in, you provide the size, the number of the tumor, and the alpha-fetoprotein value before and after bridging therapy. And this Metro Ticket is going to provide you the calculated expectancy of survival with and without the tumor recurrence within the next 5 years. It works and is validated in a huge cohort of patients from West and Eastern world. The actual treatment strategies of hepatocellular carcinoma in setting of transplantation, and not only of transplantation, are in Western world mainly summarized in the BCLC classification, Barcelona classification, and which divides the different stages of hepatocellular carcinoma in very early stage, intermediate stage, advanced, and terminal stage. Until few years ago, only patients in early stage or intermediate stage, which could be downstage to A, were subjected to liver transplantation. Nowadays, thanks to all the strategies we have in form of interventional and oncological tools we have, we can go even from propose liver transplantation also for patients with advanced stage C. And this is the new strategy proposing even immune therapy in combination to tyrosine kinase inhibitors to bring this patient from stage C to stage A or B, but proposing them liver transplantation. What about perihilar cholangiocarcinoma? Perihilar cholangiocarcinoma, in the past, they had bad results. The first series until the beginning of 2000, we had very poor results in terms of 5-year survival. The patients were not selected and were occasional findings, so the initial experience was very bad. But When selecting the patient according the Mayo criteria, as here reported, the inclusion and exclusion criteria, mainly small tumors, unresectable, smaller equal than 3 centimeters without extrahepatic, intrahepatic metastasis, could provide very good results, provided that they undergo a perioperative aggressive chemo and radiotherapy informed from external beam radiation therapy, infusion of 5-FU over 3 weeks, brachytherapy, and. So if you undergo, if this patient undergo this very aggressive preoperative treatment, the results of liver transplantation at 5 years can be more than acceptable, if not even good, as you see here in patient affected of PSC. So patients with PSC do even better than de novo, or providing even so more than 60% survival rates at 5 years. According to the guidelines or the suggestion of the International Liver Transplant Society, therefore, liver transplantation should be offered to unresectable perihilar cholangiocarcinoma, selection based on Mayo Clinic criteria, and the patient should undergo a neoadjuvant chemoradiation prior to liver transplantation. In Europe, at least we have small numbers and not everybody is using Mayo protocol or similar. Indeed, the very recent paper from France showed that comparing an international multicenter of 2 cohorts in patient transplant between 2011-2021 for a resectable perihilar cholangiocarcinoma, selecting according to the Mayo Clinic criteria, receiving or not receiving the neoadjuvant treatment, they could show that the survival didn't change significantly if the patient got or didn't got the neoadjuvant treatment. So, at least in Europe, is still discussed the role of neoadjuvant treatment. In case of intrahepatic cholangiocarcinoma, there are 2 kinds of intrahepatic cholangiocarcinoma. Very early intrahepatic cholangiocarcinoma, usually as occasional finding in cirrhotic patients, usually undergoing liver transplantation for hepatocellular carcinoma, which demonstrate to be intrahepatic cholangiocarcinoma, and patients with more locally advanced intrahepatic cholangiocarcinoma, where the extent of liver resection make this option unfeasible. So therefore, patient with unresectable intrahepatic cholangiocarcinoma. In the first case, so small, less than 3 or even 2 centimeter, unresectable in cirrhosis, intrahepatic cholangiocarcinoma, the group from Toronto and from Japan showed in very small series, 29 patients and 48 patients, excellent 5-year survival rates up to 73% or even up to 65%. For more advanced intrahepatic cholangiocarcinoma, considering the patient should undergo neoadjuvant or adjuvant chemotherapy according to the tumor biology and selected according to this parameter, the group from Houston showed in very few patients, in this case 18 patients who underwent liver transplantation, this patient who underwent pre-transplant treatment and downsizing and control of the disease with stable disease along 6 months, you can see here at 3 years 71 or 57% overall survival. These are amazing results, almost, at least in Europe, not reproducible, but this is the way we probably can go in the next future. Another indication for transplant oncology is represented by the metastatized neuroendocrine tumors, which can be classified according to different classification, Milano, INETS, and UNOS classification. If you consider this selection criteria, age less than 60 years, G1, G2, primary tumor drained through the portal vein system and involving less than 50% of liver parenchyma, and with also in this case good response to therapy before liver transplantation and stable disease along 6 months, you can reach excellent results at 5 years, or in this case even up to 10 years, of 45% and 76% respectively. If you apply in particular the Milano criteria, you can see fantastic, which are very, very selective criteria. You can see here at 10 years, almost 90% survival of patients and a clear transplant benefit in comparison to patients with similar extension of disease getting no transplantation. The problem in this case is when to transplant this patient, because neuroendocrine tumor maintain very stable along the time, and you can have a patient with metastasized neuroendocrine tumor for also some years. So the idea is when to perform this transplantation. According to the paper published by Vincenzo Mastaferro in Lancet Oncology a few years ago, that you should keep constant the disease. As soon as the disease is going to start to be uncontrolled, is this the time of transplantation. Another indication for transplantation, transplant oncology, are the hepatic hemangioendothelioma, which are quite aggressive malignant vascularized tumor belonging to the group of sarcoma. And if you select them according to the score criteria published by Quirin Lai and Journal Route 2017, according to these points of selection criteria, waiting time, the microvascular invasion, and lymph node invasion, as selection criteria, you can have excellent results. It is important eventually to perform whenever possible to distinguish hepatic hemangioendothelioma from hepatic angiosarcoma through gene analysis. And in this case, if you can do that, it's important to even improve the results of any other subgroup of hemangioendothelioma. And we are coming now to the last and most important, or most actual a new indication of liver transplantation in setting of transplant oncology, namely liver transplantation for unresectable colorectal liver metastasis. What does it mean, unresectable colon metastasis? It means that in less than, let's say, 30% of patients affected of colorectal metastasis, a liver resection is possible. On the other side, more than 60% of patients affected of colorectal metastasis have an unresectable disease. If you can resect them in an hypothetical curve, you have very good results, or more than acceptable results, around 50% at 5 years. But if they are not resectable, they have a survival rate expected less than 5% after 5 years. And we are talking mainly of these patients with the disease distributed both liver lobes, which cannot leave you any chance to survive of resection. Very recently, the International Hepatopancreatobiliary Association published in Lancet Gastroenterology and Hepatology some guidelines regarding liver transplantation for colorectal metastasis. So, in case of absence of extrahepatic metastatic disease, patients fulfilling particular molecular criteria, mainly no BRAF mutation, provided that the primary tumor has been resected, and provided that this patient have a sort of answer or response to the standard chemotherapy you can do, these are good candidates for liver transplantation. Remember, Lancet Gastroenterology Hepatology, International Society of Hepatobiliary Surgery. Very recently, the group from Oslo, which provides actually still the hugest experience in liver transplantation for colorectal metastasis, published in JAMA Surgery excellent results of liver of overall survival at 10 years and providing a survival of 60 months. So overall, 5 years in all the groups, but in selected patients according to the Oslo criteria, largest tumor size, progressive disease while receiving chemotherapy, CA80 microgram per liter. If you see all these parameters in these curves, if this prognosis factor, poor prognosis factor are met, the results are bad, but if they are not met, you can see excellent results even at 10 years, up to 40% if all their patients are dead. In particular, we should consider nowadays the role of metabolic tumor volume at PET-CT and the primary tumor in the ascending colon, so right hemicolons. The location of the primary UC plays an important role, and also the metabolic PET-CT metabolic tumor volume an important role. So selecting the patients according to this criteria may provide you excellent results. So again, just to summarize, right-sided, undifferentiated with extrahepatic disease, BRAF mutated and with progression do bad. And if you get 100 patients coming to you with the unresectable colorectal metastasis, once you select them, you have less than 5% who can be fulfill the true criteria for liver transplantation with good results after a long time. It is important also to know, if you now compare these results, the results of standard indication for liver transplantation in terms of transplant oncology, the results reported on the right are very similar, if not better, to the standard indication. So the colorectal metastases they have no inferiority, let's say, in different words, or even better results. Many studies are running about liver transplantation for colorectal metastasis. Very recent study has been closed and presented at ASCO meeting in San Francisco. Professor René Adam from Paris reported the results, and the results have been published in Lancet 1 month ago. And you see, randomized control trial is the first and only randomized control study in which patients affected of unresectable liver metastasis undergo chemotherapy before liver transplantation, then liver transplantation versus chemotherapy alone. And you can see a huge difference between the two groups. In intention to treat population, the 5-year overall survival was 56% for liver transplantation versus 12%, and 73 versus 9.3 for per protocol population. So amazing different results. So in other words, it seems that liver transplantation for colorectal metastasis play a relevant role, better than any other therapy. The only price we have paid with that is early tumor recurrence and mainly extrahepatic. But if you can detect the extrahepatic disease and treat them locally, surgically, or through chemotherapy, you can even get good results. So therefore, liver transplantation from colorectal metastasis could be somehow considered a very excellent palliation or even cure of disease. What can we do now in times of organ paucity? We do not have, at least in Germany or in Europe in general, in the non-EU country, not enough organs for standard organ indication. What about for colorectal metastasis or ultra-extended indication? You see, in terms of disease donor transplantation, Germany has very, very poor results. There are other European countries with a lot of organs available, like Norway. Italy and Spain are doing good, but Germany, in our case, doing very poor. With the consequence, with high rates around 20 up to 30% of mortality on waiting list for standard indication. What can we do with this? So there are different proposals. One of them use extended criteria donor, DCD donor, split, and living donor liver transplantation. Let's stay on living donor liver transplantation. There was a paper we published a few years ago showing that the living donor transplantation in Europe was not existing. And very recent paper confirming that living donor liver transplantation in Europe, in comparison to Asiatic countries and including Turkey, you can see here, living donor transplantation plays in Europe mainly a relevant role only for children. Why is this? Because I don't know actually, but if you ask ChatGPT, you get a long list of potential answers, and you realize that most of the people are afraid of the risks taken by the donor. Under the concept of double equipoise, the question is the risk taken by the donor worthy for the benefit of the recipients? On the other way, do the recipients' benefit justify the donor risks? And again, if you ask which are the solutions, you ask ChatGPT, they say you should improve your surgical technique and post-operative care, maximizing the safety of the donor. The actual trends in living donor liver transplantation seem to push the indication to perform more and more left lobe transplantation more than the right one for the safety of the donor. And let's go to the final part of my presentation in terms of extending not only the indication, but the technical strategy we can apply for this kind of indication. And I'm talking applying, putting together all what we know in transplant surgery together what we know in hepatobiliary surgery. And this is the rapid technique. We can be summarized in 2 words: APOLT, auxiliary partial orthotopic liver transplantation, put together with the basic concept of ALPS procedure. In order to name it as you like, it is nothing than a 2-stage auxiliary liver transplantation using very small grafts, usually left or left lateral, from deceased donor or living donor, with and without portal inflow modulation, and in a second time, delayed removal of the remnant right native liver. This sound very new name, new concept, but the history is very long. Started already in the 90s, even in the 80s, and becoming reality in the 90s in Hanover, and then applied for other indications. You see, initially metabolic disease, acute liver failure, and small for size graft in cirrhotic patient in the late 90s. We published the first case, or the first time, the technique of living donor rapid procedure, which consists in nothing else than this. I can tell you very shortly. You have a patient with full of a colorectal liver metastasis. You remove the left lobe, keeping usually the middle and the left hepatic vein, and the branches of the left portal vein and left hepatic artery. You procure the left lateral lobe of a living donor, and you implant here in this way, perform the venous anastomosis, the portal vein anastomosis, the arterial anastomosis, and close the right portal vein, allowing, according to the ALPS concept, a fast regeneration of the future liver remnant and get a sort of atrophization of the native lobe. These are the techniques of portal vein anastomosis, hepatic artery anastomosis. Then you perform the biliary anastomosis in terms of biliodigestive duct-to-duct anastomosis. Then you stop according to ALPS procedure. There is an interface period in which you measure the function and the volume. And once the volume is regenerated, you perform usually 2 weeks later the removal of the native liver, open or laparoscopically. It's important during the interphase and intraoperative mainly to measure all the hemodynamics parameters, mainly portal vein pressure, the hepatic vein portal vein gradient, portal venous flow, and to apply all normotensive setting on in hypertensive setting, graft inflow modulation or portal vein ligature according to the parameter measured. You can apply this technique in not only in normotensive setting like oncological indication, but again for intermediate hypertension like in acute liver failure, or of course in hypertensive setting like small for size grafts in cirrhotic patients. This brings you to a minimal risk for the living donor with a maximal benefit for the recipient. Which is the future? The future and the idea is what we, our oncologists from Tübingen published very recently, last March in Cell. So undergoing an important aspect of biological regeneration of the liver. There is one very important molecule, the MKK4, which is able to inhibit the regeneration of the liver. If you inhibit the inhibition, like twice minus minus, like in electricity, you get a positive effect. By inhibiting this molecule, you have a fast regeneration of the liver. And this has been demonstrated in mice and in pigs undergoing major liver resection. So the idea behind this is that probably we can perform more and more very extended, not only liver resection, but also liver transplantation using very small grafts, pushing their regeneration with these new molecules. This is the way we are probably going, and this will be the next future, and this is also our dream, which is going now in a phase 2 phase. Thank you very much for your attention, and happy to get some questions, if any, from you.
Thank you, Dr. Silvio, for your interesting talk. I have a question. How many rapid procedures did you perform?
We perform now 5 rapid procedures, and I'm talking about the study running here in Tübingen and Jena, the so-called liver to heal study. We've made 5. The colleague from Jena performed 13. There was a very recent paper published by Sedmacher collecting all living donor rapid procedure worldwide. There were 2 years ago almost 23 cases, and being 20 of them being for colorectal metastasis. But all of them confirm the results published very recently by René Adam.
Great. Okay. Any questions from the audience? Please, if you have a question, raise your hand. Dr. Medhat, do you have any questions? We can't hear you. Unmute.
Thank you, Dr. Nadalin. How about if we do liver transplant, how often do you get rapid recurrence from immunotherapy?
By the way, Dr. Medhat was the first to perform liver transplant in Egypt years ago.
Congratulations, amazing. So therefore, respect for your huge experience. Yes, this is a very good question. The recurrence of disease...
The original primary.
Pardon?
The original primary due to immunosuppression.
No, we don't. The original primary due to immunosuppression, we don't have the recurrence of the original primary in terms of local recurrence. You have recurrence of metastasis mainly outside of the liver and mainly in the lungs. And although you have recurrence, we and the most the biggest series from Oslo, you are able, because these patients undergo very accurate follow-up, and they're going to be treated very successfully, and so therefore they will survive a long time.
And so you go for lung resection in these metastases.
For example, you can, a very interesting case, one, maybe the first proposed, so reported by Oslo Group, is still alive more than 11 years, still with very small metastases they keep under observation. So you can observe them, you can burn them with ablation treatment, you can resect them, do whatever you want, so far you keep them under control.
Okay, thank you.
You're welcome.
Hello.
Okay, do you have any other questions?
Do you perform in Egypt liver transplantation for colorectal?
We don't.
ده التشو قاعد يتحرك.
We don't perform it at our institute anymore.
لا انت خد له
But wait, I have to mute Dr. Medhat. It's performed in other hospitals, so I cannot. I don't have the enough knowledge to answer this question. At our institute, it was the one of the first places to do it years ago, maybe 20 years ago. But Dr. Medhat can tell us exactly when. But right now, we don't do it at our institute, but other institutes do it. I don't have enough information to answer the question.
Okay, but I'm sure that this study of Professor Adam, the TRANSMET study, is going to push so this kind of indication worldwide, and with these excellent results. Yes, maybe coming soon even also in your country, because it's very diffuse disease.
Yeah. Okay, great. Any other questions from the audience? Last chance to ask a question. Have you ever been to Egypt before?
Pardon? No, not yet. Not yet, no.
Okay. Maybe soon.
Maybe soon.
If you come, you let me know.
Of course, I'll do it.
Okay, so I guess that was it.
No other question?
Yeah.
I go back to the OR.
Yeah, good luck in the OR, and I will send you the video tomorrow.
Thank you so much, Shaman. Bye-bye.
Thank you for doing this.
Thank you to
Good
everybody.
night, everyone.
Bye-bye.
Good night.